Okay, this is going to be the second half of chapter 12. Let's start out with traumatic brain injury. Traumatic brain injury is an acquired injury to the brain that's caused by an external physical force, resulting in total or partial functional disability and or psychosocial impairment that adversely affects the child's performance educationally, but could also be socially. Can result in impairments in one or more areas: cognition, language, memory, attention, reasoning, abstract thinking, judgment, problem solving, sensory, perceptual, and motor abilities, psychosocial behavior, physical functions, information processing, and speech. So, we've got a wide range of things that we could be working on with kids with TBI. TBI can result from bruising and laceration of the brain, from coming into contact with the rough inner surface of the skull. That can be due to edema, which is going to be swelling, and then your brain's going to rub up against the skull. Infection, hypoxia, loss of oxygen, pressure, again from tissue swelling, a stroke. It could be from hematoma, which is a blood vessel bursting. However, right, it can also be due to, right, the leading causes are going to be falls, motor vehicle accidents, blows to the head in sports. Two of the biggies in the U.S. are going to be football and soccer. Any kind of physical assault are going to be the big causes. And there are two main types of TBIs. There's going to be an open head injury, which is going to be localized, and or a closed head injury, which is going to be more diffuse. So an open head injury is where something goes through the skull and into the brain. That could be a gunshot, a knife, right? Something going in. It's going to specifically impact the area of the brain that was touched with the bullet, the knife, the whatever goes through your skull. And or a closed head injury. So, and this is going to often be from a motor vehicle accident, right? If you are in a really bad accident, the front of your head hits the window of the car, the front of your brain then smacks the front of your skull. You then do a whiplash, and the back of your brain smacks the back of your skull. So now you've got, injury to the front and the back, or it could be side to side, right? So open head injuries where something goes through the skull are usually going to be localized to what actually touches the brain, whereas closed head injuries, your brain is hitting your skull in many different ways, and can cause multiple problems. About 1.5 million people sustain a TBI every year. Males are going to be twice as likely to have one. At least 5.3 million Americans currently have a long-term need for some kind of help as a result of TBI. So some characteristics: we're going to have an inability to resume interests and daily living tasks. It's going to impact orientation, memory, attention, reasoning, problem solving, executive functioning, right? Making things really difficult to do, right? And about 3/4 of people with TBI, it's going to impact their language in some way, either, and it could be form, it could be content, and it could be use, right? It could be across the board. The two most commonly reported symptoms are going to be anomia and overall impaired comprehension. When we're talking about anomia, we're really talking about labeling and a student's ability to name objects, or a person's ability to name objects. I'll never forget the first time I worked with somebody who had anomia. I was getting some hours in a VA hospital, and a man came in who he'd had a stroke and not a TBI, but this is what anomia is. And he owned some houses locally, and so he was the person who went in anytime there's a problem. He would go in and fix them. So he owned them, he rented them out, he made repairs, and his family were not letting him do that anymore, and he was really upset about it. And he was kind of coming in to get an assessment that said, hey, I can do this. Please leave me alone. So we were talking, and he was telling me all these things. And then we did some testing, and he was able to do everything. And I was like, wow, what is this family doing? Like, why? This person has no trouble at all. And then we went to the naming. And the very first one, I flipped over a picture, and it was a picture of a hammer. And I said, what's that? And he said, oh, it's when you take it and you hit, and you hit with it, and it goes together, and or breaking. And he talked for a little while. And then I turned over the second picture, and he couldn't name that, and the third picture, and he couldn't name that. And it was like, wow, like he was completely intact, but he could not name objects. And that was his big issue. So that's just, he had pretty much straight anomia. And then you also have overall impaired comprehension, where you just can't remember what people are saying. You can't comprehend and understand what they're saying to you. You can't understand what you're reading. You can have an inability to inhibit behavior, errors of judgment, rambling speech and incoherence, poor turn-taking skills, poor affective language abilities, inappropriate laughter and swearing, right? So if you get some kind of a right brain impact, it's not unusual to then have a lack of inhibition, a lack of filter, where the person just says or does whatever they're thinking without that sort of reasoning behind it, going, oh, I shouldn't do that, or I shouldn't say that. People are going to have speech, voice, and swallowing difficulties. About 1/3 of individuals with a TBI are going to have dysarthria, right? So that's that muscular weakness leading to a speech disorder. We're going to have psychosocial personality changes, may include, again, disinhibition or impulsivity, poor organization and social judgment, and either withdrawal or aggressiveness. Physical symptoms may include difficulty walking, poor coordination, vision problems. Severity is going to be related to initial levels of consciousness and post-traumatic amnesia, right? So right after it happens, when the person's in the hospital, you're usually going to do some kind of a coma scale rating. Is the person conscious? Are they able to talk? Are they able to acknowledge you? Are they in a coma? Right? That's going to tell us what kind of severity we have. Language characteristics. Language difficulties resulting from TBI can involve expressive and or receptive language, and it can range from mild to severe. So it can be across the board. It can be everything. It can be one thing. The most disordered part of language is going to be pragmatics and syntax. But again, if you have anomia, right, that's about content and vocabulary. Children who lose language functioning as a result of brain injury are going to have it says acquired aphasia, but aphasia is acquired, right? Aphasia is an acquired loss of language. So you already have language and something happens and you lose that language, that's aphasia, rather than a developmental language disorder where you've never had skills that you're supposed to have. In addition to impacting language and communication development, brain injuries can also have an impact on literacy skills. Children with traumatic brain injuries have been found to score significantly lower than age, gender, and race-matched injured children on achievement tests of reading, language, and mathematics. TBI intervention is going to be, we're going to talk about cognitive rehabilitation. There can be a restorative approach where you help them gain skills that they used to have and you regain those skills, and or a compensatory approach where you help them manage and cope with skills they no longer have with new skills. Early stages of TBI, we're going to have orientation issues. There can be sensory motor stimulation needed, recognition of people, of objects, of places. In the middle stages, we want to try to reduce confusion. We want to improve their memory and their goal-directed behavior. So starting to think, okay, at the very beginning, just helping them orient, helping them understand, making sure they know, just things like light and sound and touch. They can recognize people. Then in the middle, right, we're going to start thinking about, can we get these people back to school, back to work, helping them be less confused, remembering facts, places, people, goal-directed behavior in terms of, right, what do I have to do today? What's one thing I have to do? How am I going to do that? And then, right, comprehension of complex information and directions, conversational and social skills, right? How much are they able to get back and do that they did before, both socially, educationally, and vocationally. Early stage recovery, we're going to simplify activities and routines. We're going to improve the patient's orientation and attention to their surroundings. We're going to pair gestures with verbal explanations so that we're not only going to tell them something, we're going to actually try to either have a picture of it and or a gesture of what we need. Not overstimulating, not too many people in the room. Lights are not going to be too bright. Sounds are not going to be too loud. Auditory stimulation is going to be the chief mode of input. Reading is going to be really difficult. Once we move to other areas, we're going to use brightly colored objects and pictures in therapy so that they're really able to see them, recognize them. We're going to start with strong cues and then fade later. So we're going to give them a lot of information and help at the beginning. As we make things harder and harder, we're going to fade our help and support and see if they can continue to answer our questions and respond. We're going to work on yes/no responses and try to go from there and to really gain the patient's attention, both in terms of what their needs are and then how they can start to help themselves. We're going to use statements instead of questions when initially communicating. Right, they're not going to be ready to answer questions at the beginning. Just using statements and seeing if they can then perform those statements. Can you Can you follow my finger with your eyes? Can you look at your husband? Can you look at your wife? We're going to allow time for the patient to take the information in, so lots of wait time, not rushing. We're going to use sentence completion tasks for patients with initiation or inhibition difficulties, right? So we're going to give them a lot of the information and just leaving one word out to see if they can fill it in. Again, lots and lots of support. In the intermediate stage of recovery, we're going to start to establish more complex routines and complex communicative skills. We're going to continue to provide stimuli as needed, repeating treatment trials. We can, again, we're going to go slowly. We're going to repeat things if we need to. We're going to improve selective attention and comprehension by asking matching questions, following directions. Can they retell stories? Can they answer questions? We're going to increase the client's awareness of problems and start to teach some compensatory skills. So even if we really believe clients can increase a skill, they also need to be able to function today. So how can you manage not being able to do that skill and still have some success with whatever task you want to try to complete? In the late stage, we're going to train more complex activities to enhance independence. We're going to diminish special stimuli that control behaviors so that we're going to start seeing if they can do things on their own without prompts and things like that. We're going to continue using shaping, modeling, prompting, and manual guidance as needed, though, for correct responses. Any kind of motor disorder they have, we're going to work on helping them learn self-monitoring skills. If they've had a right brain injury, that awareness and that ability to self-monitor is going to be tough. Again, we're going to go slowly. Again, teaching compensatory strategies and also teaching organizational strategies, right? They may never have needed to keep a journal before. They may never have needed to keep reminders up in the house, to make lists of things, to try to do the same things every morning so that you don't forget things or leave things. You want to teach the patient to copy and recognize letters, numbers, and words that they would see every day. Help them develop core vocabulary, words that are most used in their environment, right? At school, at work, at home, right? What are the most important words? We're going to work on those first. And then along with all that, we've got 10 main elements to consider. So having a maximally controlled environment. The child may need a really highly structured environment where distraction is reduced. Can be really helpful. A low pupil-teacher ratio. It might be helpful to provide a classroom aide or other assistants to work with the child. So more adults per every child. They're going to need intensive and repetitive instruction. Again, going slowly, repeating things. These kids are going to need more time to learn. Maybe reducing non-academic activities and lengthening the school year can provide more learning time, right? But we also want to make sure that they're participating in life and doing things they enjoy, and that things aren't always difficult and hard. The emphasis on the process. The child might need help in learning how to learn. So help in sustaining attention and on memory rather than just on specific skills. We're actually learning about the process of learning. We'll be doing behavioral programming Instructional strategies that use task analysis and careful measurement of progress are often successful. Integrating instructional therapies, integrating allied therapies such as speech and physical therapy into the student's primary instructional setting for generalization and transfer of skills. So trying not to do all therapy and pull out by themselves, but if we can do it in the classroom while other things are going on, that'll be really helpful. Using simulations can be helpful to enable the child to transfer skills to a new setting, so that, you know, if you do have to pull them out for therapy, you could bring in some classmates and you could simulate a classroom experience where you're the teacher, you're asking questions, seeing how well the child keeps up with classmates. Cueing, fading, and shadowing. Students may require cues to respond, which should be faded as soon as possible. When shadowing, the teacher closely monitors the child attempting a new task or moving to a new environment. Readjustment counseling may be really important to help the child adjust to his or her new environment and abilities. So just getting them used to being in the school and where to go in school, where to sit down, where to keep your pencil and your paper and your books, just helping them be readjusted to things, introducing them to a few classmates at a time. And then having a homeschool liaison. It's essential to build and maintain a strong link between the parents and the school. So making sure that we're in constant contact with how are things going at home, what do they need at home, what's working, what's not working, and then making sure the parents know those same things at school. What do they need at school, what's working and what's not working.